Hello, everyone. A warm welcome to today's third module of our EBUS certification course. It gives me great pleasure to invite all of you to this very unique and innovative online EBUS certification course, which is the initiative of IIB, our Indian Association for Bronchology. As you all know, IIB is a national body for interventional pulmonology, and the IIB GC would like to facilitate maximum IP training for one and all with this very unique and unprecedented online EBUS certification course. Through this course, we are bringing EBUS learning to your doorstep. This EBUS certification course will consist of 10 online modules. And after this, there'll be 4 physical workshops on 4 different Sundays in 4 different parts of the country, north, south, east, and west. To get the certification, you need to attend at least 8 out of 10 modules live, and you need to attend any one workshop that out of the 4 that we are conducting. uh, I think it's going to be very, very informative. It's going to be a great certification course, because normally in a workshop, what we hear for 15 to 20 minutes in a talk, today it will be discussed for 1.5 to 2 full hours by the bestest faculty of our country. We are going to learn just so much, and all the doubts that we've had till date will get beautifully cleared. So, with this brief introduction, I think we can start our today's webinar. I would like to thank Mankind, especially Nitin and Manoj, for being absolutely wonderful support and help. And I would also like to thank Olympus for being our academic partners. With this brief introduction, let me invite today's moderator, captain of our ship, none other than Dr. Prashant Chajid. Dr. Prashant requires no introduction whatsoever. He is the pride of Maharashtra. He is the man who does maximum interventional pulmonology in our Maharashtra, and also one of the best IP in our country. He is the consultant at Nanavati Lilavati Fortis. He is an avid academician with, I don't know how many publications, but I think he's got highest publications in international journals in our country, and I'm pretty sure that I'm correct. He's a brilliant physician and a very, very dear friend of mine. So over to you, Prashant. Please take us over through this webinar.
Thanks a lot, Amita, for those very, very kind words and the introduction. I think you've spoken more than I think what I deserve. Yes, we are published, but I think there are many, many people who are also well published here from AIMS, from PGI, and all. But yes, I think it's a great thing to contribute to research and academia. And I think that's what I think all of us should contribute as much as we can, even if our primary interest is clinical medicine. I think EBUS is a very, I mean, clearly a very important diagnostic tool. It's part, it started about 20 years ago when we did it, when we introduced EBUS. That time it was just a tool that was used by select centers. It was mainly used for lung cancer diagnosis, staging. That was the dominant indication. And gradually, over the last 20 years, and more so over the last 10 years, we have seen an amazing uptake about EBUS, TBNA all across India, into all, not only limited to the metropolitan cities, but also we have seen it in all the second tier, third tier cities. What it means is that people all across the country have a better chance of getting the benefits of EBUS TBNA, because the dimensions of EBUS TBNA in our country is not restricted only to cancer, but is also linked to infections, and particularly tuberculosis also. And clearly, we've all seen how it aids us to not only differentiate cancer and benign conditions, but also helps us to make a histological or a microbiological diagnosis of maybe TB also, and also maybe MDR TB. So clearly, I think EBUS has been adopted very well. It was a part of interventional, so-called interventional pulmonology, but I think it is now graduated to become a part of conventional bronchoscopy suite. And that's because of its wide application and the opportunity which it gives all of us to move towards either a pathological diagnosis or a microbiological diagnosis. So, I can keep talking on it, but without wasting further time, we've got like Amita said, this is uh, we've got a fantastic faculty. We've got a huge opportunity to learn not only about the data they present, but also the comments. I would urge all of you also to listen to their comments and the experience, because that's what it's all about, in addition to the data. So for the talk, for the speaker for tonight is Professor Dr. Karan Madan, who is professor at All India Institute of Medical Science, Department of Pulmonary Medicine. He focuses on pulmonary critical care and sleep medicine, and has a lot of publications. You see, you will, if you look up, open up the journals, almost every month you will find Karan's name on some paper. So that's an amazing contribution towards advancing clinical research within India. So, and I'm a firm believer that, I'll take a couple of minutes more. I'm a firm believer that we need Indian data to support our Indian clinical diagnosis and understanding. So Karan is clearly interested in interventional pulmonology, sarcoidosis, meta-analysis, randomized trials. And there you go, Amita, as I said, more than 318 publications on PubMed, which is great, has got multiple awards. And Karan, have known him for many years. Very He's a fantastic teacher. We've associated for several courses, several workshops, and his teaching is exemplary. So over to you, Karan, and Karan is going to tell us, how he does EBUS, and more than, it's a topic of how I do it, but I think it's more of what are the critical steps in the performance of EBUS, and that's what we are going to learn from Karan. Thanks a lot, Karan.
Before Karan starts, Prashant, I would like to completely agree with you. I mean, we could have not had anybody better than Karan talking today to us, about step-by-step Convex Pro EBUS. And I completely agree. Karan really makes us proud. I mean, fantastic physician and really an avid researcher and a great publisher. So, and I was really hoping that Karan could take this talk, and I'm so happy that he was available and free. So, Karan, I'm looking forward to listening to you. Over to you.
At some point, Karan, Karan, if you permit me, can I expose one of your secrets, one of your passions, hobbies?
Yeah, please go ahead. Yeah, yeah.
Yeah, Karan plays fantastic drums. Okay, so Karan
And he
has
even
a hobby
sings
of
better than
musician.
that. I've heard him sing. He
Right,
sings
right,
so
right, right,
awesome.
right.
So now we know after the EBUS course is over, we can have Karan's performance.
Yes, yes, no, yeah, yeah. Okay, over to you, Karan.
Yeah, yeah. Thank you, Dr. Prashant. Thank you, Dr. Amita, for this, generous invitation to have me here for a generous introduction. I mean, Dr. Prashant, a long association. We've been friends and, have a long association at Dr. Prashant's meetings also. A lot of learning, a lot of teaching, and that's how, we grow in time. And can I just share my screen here? Yeah. Can you see my screen here?
Yes, we can, Karan. We can. Just need to get into slideshow mode.
Okay. Right.
Okay.
So I think talking about EBUS TBNA, I'll keep this talk very, very practical. This is going to be, just about the technique. It's going to be a lot of videos, a lot of images, how you actually do the procedure. And, the topic has been how I do it. So I think I'll put my perspective, like how we do it. And, there are always a little bit of differences, and that's the part of learning, and we'll discuss it on the way. And I think I've been given some time, but if I, overshoot by a little bit, I think I'll request the moderators and the panelists to, just bear with me a little bit.
Dr. Karan, we've given you 20 minutes, but we want you to talk for
Right.
25 minutes.
No,
So
no.
please go
Yeah.
ahead. You may go overboard.
Yeah. So I think this was how I do it. I mean, so if, old timers, it was like thinking of me as an old timer. But I think if we talk about the history of EBUS introduction into India, I think we were one of the, centers who adopted this technology early. I think it's now been 13 years since we've been doing it. And I think it's a continuous learning because the technology keeps on coming, technology keeps on evolving. And that's why it's important to be updated with what's available. So before I begin my talk, I would like to introduce everyone to these two papers. The one on top is the EBUS guidelines from India, and that's the Joint Indian Chess Society and the IAB guidelines that were published quite some time back. And the other paper at the bottom is the survey of EBUS practices in India, which we published 2 years back, which gives you a good idea about what your colleagues are doing, as to what your fellow colleagues are doing. So I think if you're interested, go through these papers, and I think you'll find them quite useful. So just introducing EBUS to you, you must have learned in the previous webinars, it's a bronchoscope which got an ultrasound at its tip. It's got a convex transducer, so that is why it is called as a convex probe EBUS. It is just like your ultrasound probe of ultrasound machines, and it is also called by the name of linear EBUS. If you see, this is what the distal end of the EBUS looks like. You have this ultrasound probe, you've got the needle which comes out at an angle, and you've got these optics which are, at an angle because the ultrasound transducer lies right at the 0 degrees. So you have to have vision which is slightly angulated. And the EBUS scopes differ in this angulation degree. That's the essential difference between the types of EBUS scopes which are available. And that we'll also see in the subsequent slides. At the tip of the ultrasound probe, you can have a balloon attachment, and this balloon can be inflated with saline because if you're not getting a good bronchial wall contact, inflation with saline gives you good contact because water is a good conductor of ultrasound. It's ultrasound's friend. On the other hand, air is an enemy of ultrasound. So if you got a lot of air between the wall and the probe, your image will really not be clear. So this is the idea. You go with a, EBUS bronchoscope. So you have lymph nodes which are lying on the side of the wall. You go with an EBUS scope, contact the wall, it gives you an ultrasound image, and then you get the needle under the vision. That's the principle of EBUS TBNA. Now coming to how it actually looks like. So this is the real image of two EBUS systems which we have at our facility. And these are essentially two parts of the EBUS system. You've got an ultrasound processor, which you see at the bottom, and you've got a video processor. So essentially, once you talk about a bronchoscope just works on a video processor and light source. On the other hand, with the EBUS, you've got this ultrasound processor. These are interlinked together and they are connected to your EBUS bronchoscope. And this image from the scope comes onto a monitor, and it's your choice what kind of monitor you keep. You can keep a huge monitor. You can keep multiple monitors in your room for teaching and training. So it essentially, comes down to what you have. Now coming on to what do you require? So obviously you require the EBUS bronchoscope. The EBUS bronchoscope, is attached to the ultrasound system, and then the other important part of the EBUS bronchoscope is the EBUS needle. EBUS needle it is a slightly complicated instrument for beginners because it's got multiple levers and instrumentation, but it is quite easy and simple as you go on. And I think I'll show it to you in the video also how you operate this needle to simplify the matter that how this needle works. At the bottom you see here is got an vacuum syringe. So you can use this automatic vacuum or vac-lock syringes, which can create an automatic vacuum, and then you can create that vacuum and attach this vacuum at the syringe end, needle end once you want to aspirate, and that also will be showing you in one of the videos. Coming to the EBUS needle, this is how you see the needle locks into your ultrasound bronchoscope. And if you will notice, needle has got multiple operating, parts. That is why what I would say that if you want to begin doing EBUS TBNA, you need a bronchoscope control along with a needle control. So basically, if you are starting to do EBUS, I think you as the operator should focus on the bronchoscope control. So you are the primary operator who performs the procedure, holds the bronchoscope, and you ideally need a trained assistant who is fully versed with how to handle the needle. So what would happen is that you can focus on the procedure, you can manage patient cough, you can have your full focus on the vision where the needle is going, and the control of the needle putting it into your scope, taking it out, getting the samples is the job which your assistant would do. So I think the bottom line is that train your assistant well so that they can handle your needle along with you so that your procedures go smoothly. So now what's the agenda for the talk now? This is how we'll go. To see how we do it, you'll see the preparation aspect of the patient. Then how do we give anesthesia or sedation? How do we decide what to give? Then how do you get the scope inside? You get the scope inside, you see the node. Then how do you get the needle into the node? And then how you eventually get the material out. So this all starts by a preparation phase, which is actually very crucial. Before the patient comes to the table in the morning, you go and see, your patient. You do a thorough review of the radiology. Like if you see this radiological images, you'll see where your mediastinal nodes are, located. If you see, and if also do a very important review of the lung windows, because EBUS TBNA, we understand it samples the mediastinum, but it does not mean that we forget seeing the lungs. Because what you would do is, if you don't see the lung windows, you'll miss important findings. Like this CT shows you extensive, nodularity. So if you don't see this lung window, you don't do a transbronchial lung biopsy at the end of the procedure, you have actually done a procedure which was not enough. So I think radiology review is very important. It tells you which nodes are there, what are the vascular structures in proximity of the nodes, and how do you need to go ahead. You check the baseline investigations. Consent is very important, and ensure an IV access. And we do it as the first thing. Once you've obtained the consent, our patients get an IV access before they move into the procedure room. You reconfirm and ensure the procedure indication. Again, see the date of radiology. Sometimes you get the patient on the table and you see that the radiological scan was, 5 to 6 months old, and that should not happen. You should have a recent radiological scan, which actually, gives you a more idea that what you're going to see during the procedure. And the discussion regarding the type of anesthesia ideally can happen before the procedure, actually patient comes that day. You can have that discussion in the outpatient, because if you use both sedation and GA, you have to titrate that which patient you'll do GA and which patient you'll do sedation. Otherwise, some people have institutional policy to do only sedation and some do only GA. So this is the radiology of the patient which I'm going to be showing you in the video how we did it. And this is morning's patient, and it actually shows you a very large heterogeneous right paratracheal, lower paratracheal lymph node. And you appreciate there's a lot of necrosis or hypodensity in the center. So our pretest probability is clearly, mostly tuberculosis in this patient. Sometimes necrosis can be seen in malignancy, but it's a stronger predictor of TB in our settings. So this is, the procedure area. You will have a similar area. The patient will be on table. The patient has an IV access secured, and you've gotten the, ancillary stuff ready, getting the local anesthetic through, getting the, area ready where your needle will come, your samples will be obtained. You get the monitoring through. So I think the minimalistic requirement is giving the patient oxygen. You can give it by nasal prongs or, by nasal prongs, or, there's data coming on high flow nasal cannula also, but I think in most patients, nasal prongs do well enough. A saturation and NIBP monitoring is a minimum which you should do. That is non-invasive blood pressure. The ECG monitoring also, it is preferable you do, but I think in patients who have a history of cardiac disease, it's mandatory. But otherwise, saturation and non-invasive BP monitoring is the minimum. Now, after your patient is there, in this case, I'm going to show you first the patient being done under moderate sedation. And the little bit of the sedation is administered, and then comes the very important part of topical anesthesia. So this is your procedure trolley. We've got the local anesthetic here. You see lignocaine, you've got saline, you've got a vacuum syringe which is going to attach the suction. You've got empty syringes which is going to be required during sampling. You've got gauze pieces to clean the stuff, to clean the needle. You've got sample collection vials, sterile vials for gene expert collection, formalin vial for clot core collection, and you also have sometimes cytology fluid vials to do cytological processing. You've got these slide, collectors, which will have the alcohol fixative into which the slides will go. So keep all this stuff ready before you begin the procedure. It will save you a lot of hassle, and it will, once it becomes protocolized, your procedure time will significantly reduce. So regarding the topical anesthesia, anesthesia to the pharynx is important. You can give it by lignocaine gargles, or you can give a 10% pharyngeal lignocaine spray. For the anesthesia of the vocal cords and the trachea, at our center, we prefer a cricothyroid lignocaine injection whenever we are doing procedure under moderate sedation. And we would inject, a 5 cc of 2% lignocaine. This takes a couple of seconds. You localize the cricothyroid membrane, aspirate the air, take the needle out, and we do it with a thin cannula. And you aspirate air and, give the lignocaine. So this two coughs which the patient has is quite normal, and you want that to happen. Because once these one or two coughs happen, they just spray the local anesthetic all around the trachea and the vocal cords and gives you an excellent pre-procedural anesthesia. And I think this works very well for us once we are doing the procedure under moderate sedation. To back it with evidence, we conducted this randomized controlled trial 3 years back. This had nearly 180 patients in each arm, one randomized to the cricothyroid injection and other to the traditional spray as you go method through the bronchoscope channel. And what we demonstrated was that the cricothyroid injection had much less cough, and it had much superior operator-rated procedure satisfaction during EBUS TBNA. And very importantly, the cumulative lignocaine dose was much lesser in the cricothyroid method. So I think this has changed our practice, and we routinely use cricothyroid injection for our diagnostic bronchoscopy and EBUS TBNA. If you are comfortable with using the spray as you go method, there was a small randomized controlled trial in which we found that if you use a lower concentration of lignocaine, that is 1% lignocaine for spray administration, that works quite well as 2% lignocaine. And using a 1% solution gives you a more liberal, volume to, go ahead with. So after this has been done, you have two approaches. Either you can do a nasal bronchoscope introduction or oral. Both are feasible. We use nasal method quite frequently. But if you have any issue with a nasal insertion, you should quickly turn to oral approach. That's the bottom line. So nasal lignocaine gel, like 3 to 5 cc, is being given in this patient. And then you are ready for the procedure. Now your patient is prepared, and you've given IV sedation. We use a combination of an opioid and midazolam. So fentanyl and opioid is our usual cocktail. So this nasal route is, we've initially used it in difficult oral insertion, but I think there's now plenty of trials which have shown that it can be used in upfront method. But bottom line is, if you get any difficulty with nasal introduction, don't force the bronchoscope. Quickly take a bite block and take the scope orally. Now, the problem with getting the EBUS scope inside the vocal cords is that in bronchoscopy, the scope is a 0-degree view. This means what you see right in front is where your scope is going. But in case of EBUS, we discussed initially that it's an oblique forward view. This means that you look at the cartoon on the right. If you are walking straight, your neck is actually looking up. So what this means is that you've got to get used to this angle. This angulation is max in a Pentax scope, minimal in the Fujifilm scope, and the latest series of Olympus scopes have reduced their angulation from 30 to 20 degrees, thereby understanding that if you get the angle more in the axis, it makes the introduction easier. So this is the major video which will cover everything that how the procedure is done. So in this case, I started off, with a nasal approach, very gently try to get the scope through the nostril. So, but what we found was that in this case, you got a little bit of nasal, you see this is the nasal obstruction. So don't meddle. Quickly, in seconds, we change to the oral bite block, and then you introduce the scope gently, over the tongue and slide it to get a view of the epiglottis. So once you get a view of the epiglottis, you go under the epiglottis and get a view of the vocal cords. You see this little trickle of blood. This is quite normal once you use a cricothyroid injection. And this is pretty fine. And sometimes you may get difficulty in getting to the vocal cords. So doing a jaw thrust is kind of very helpful. Once you do a little bit of jaw thrust, you can easily approach the cords. And if you see, you notice this was the entry angle. I'd like to, focus it again. So I just transiently stop my video. So this is the kind of angle. So this is the vision you should have. You should not see the vocal cords in entirety, because if you are seeing the vocal cords in the entirety, this means that you are going to enter the esophagus. So if you see the anterior commissure, this means that you are in the center, and this is quite, okay to go in. So then you can gently, go in, and this patient had cricothyroid injection, and you see there was hardly any cough in this patient. Once you get inside, the second part is to give some local anesthetic spray to the carina area and the bronchi, and then you do the EBUS screening. So the patient CT I showed you with a large paratracheal necrotic node. So we are screening, the EBUS, and you see this image. It shows you a very huge, heterogeneous necrotic right paratracheal lymph node. You see a lot of hypoechoic areas inside the node. These are, coagulation necrosis sign and heterogeneity. And this also is a bulging appearance. If you see at the bottom, now once we switch color Doppler on, you see the superior vena cava at the posterior aspect. So you see the bulging appearance of the node abutting the SPC. So this is quite a large node, lower right paratracheal 4R node, and heterogeneous ecotexture, coagulation necrosis sign. So our pretest probability of tuberculosis is quite high in this patient. So once you've done that, you can do a nodal sizing. You can put your markers, and you you can put the markers, and this can help you in nodal sizing, and you can get an idea of the node. That you can also get an idea, this shows what's the dimension, like approximately 3.5 to 2 centimeters, and this gives you an idea that how deep you can take your needle depth. Also, some EBUS processors have the elastography function. Elastography function is a hardness measure. So what it actually does is that once you put this function, it gives you this color map of the lymph node. So blue usually means a hard node, and red-green means a softer area. So I think what we found is this is not a very, very useful measure, and we will show some data that, whether it works well in, any diagnostic use. So I'm sorry, I think this video got here. Okay. So once you've done that, the next part comes as the, sampling. So you get the EBUS needle through. So this is the EBUS needle. We always prefer to use a new needle. And this needle, has various portions. It's got, these 3 levers. This is the pushing portion at the top, and this is the sheath adjusting portion at the bottom, and a lock at the very bottom. So this has got a stillet inside. The stillet, can be withdrawn while you are about to puncture. And this is the needle length adjuster. So you can, fix it at the desired depth where you want to, needle, how much you want to go in. And then this is how you see, once you push this portion, you see the needle comes out. So this is the top portion, is the needle moving portion. And once you've ensured that needle is working, you also, prepare this, automatic vacuum. This is the Vaclock syringe, in which we are getting this automatic vacuum through. So you can adjust it at 20 ml pressure, 15 ml, 10 ml, 5 ml. So you can try a procedure without suction. You feel that material is not coming, you can, put on suction. Now you're ready to get the needle in. So this is the needle adapter. So you get rid of the biopsy valve from the top and exchange it with the, needle adapter. So this needle adapter is now, put onto the scope, fixed into position. And now the needle is confirmed that it's safe, it's logged in, and now the needle is inserted into the EBUS bronchoscope. So you see, I am holding the bronchoscope while the our assisting, nursing staff is helping getting the needle in. So once the needle is in, it is locked firmly into this place by the bottom port. And then you use this bottom sheath adjuster to get the needle sheath into view. So you focus on the top, 1 o'clock. You see, this is the, the plastic portion. The sheath has come into view. This means that now the needle is safe for puncturing. So once the sheath is out, you now adjust the needle depth. In this patient, I've adjusted around, 2.5 centimeter, because we know it is 3.5 centimeter node. And you withdraw the stillet back. If you're not getting a good contact, you can use a balloon inflation here. And, this point is for balloon inflation. Once this is done, you are ready to puncture. So you push the needle from the top and get the needle into the node. You get this stillet to, expel out the cartilage material. You can, withdraw this stillet and do this procedure without suction. I'm demonstrating it. This is how you do it without suction. You aspirate, you do these agitations, or you can connect a suction here and then switch on the suction, and then you do this agitation, and you take care that blood is not coming. Do around 10 to 20 revolutions. And very importantly, switch the suction off before you pull the needle out. This is very important, because if you won't do that, we switch the suction off, and then you firmly and briskly take the needle out and hear that click sound. This means that needle is firmly in, and then in one quick go, you just take the needle out. So once the needle is out, now the sample has to be obtained. This is from our patient. You can, put the stillet and see, we got this pus material in the morning today. This was, anticipating tuberculosis. And so once you get this material, there's no need to make a lot of slides. You have to, take care that this material, goes for maximum as microbiology. So this is the sterile vial into which this material is being obtained for gene expert and microbiology testing. And this is the, purulent material which was obtained in this patient. This was a little bit of material sometimes can be left in the hub of the vacuum syringe, and this also you can, push it out, and this can be, taken into the vial. And this is how, the procedure is there. And then the material which you got on the slides, you can take material and make a few slides. So you can make fixed slides which go into alcohol, and then you can make air dried slides in this case, which will go for AFB smear testing. And you should not wait for slides to dry. As soon as you smear less than 5 seconds, you get those into the alcohol. So don't, wait for slides to dry out before you get into alcohol. That leads to artifacts. This is how the image looks on the ultrasound. That you focus on the top 1 o'clock corner, and this, how it looks like once the needle is coming in on an ultrasound view, and you see how the needle is being agitated inside the lymph nodes. And in these cases, sometimes we target the coagulation necrosis areas because we anticipate that those areas are the ones which are going to give us pus. So this was essentially the video. I think rest is pretty brief. I'll sum it up. If you use a 10-degree forward viewing scope, this is the Fujifilm scope. The image is a little different. I'll show you how it differs. This is the second patient of today where we did through the nasal route, and this nasal insertion was quite comfortable. And if you notice here, the image is a little different. You see, this is a slightly forwardish view. This means that you don't need to, do that lot of, anterior viewing of the cords to enter. You can just get a view as you do in a routine bronchoscope, and you can, enter the vocal cords. And how I'll also show you how the puncture angle differs in this scope. So this is how you see the sheath right in front of the view. And, the puncture angle is a little more vertical. In the Olympus scope, it's a little more angulated, and in this scope, it's a little bit, more verticalish angle. So practically, it does not make much of a difference in terms of the angle. So a little bit of data. I showed you something about elastography. Whether doing that color mapping, elastography is useful. It takes time, but we did this meta-analysis a couple of years back, and we found that it can be useful in differentiating benign and malignant node, but it does not obviate the need for sampling the lymph nodes. So it can give you an idea, but you still have to go ahead and sample nodes. And we found that it does not help much in differentiating tuberculosis and sarcoidosis in our cohort of patients. Another, thing is regarding the pathology. So if you see the image on the right, you sometimes get this kind of, core tissue. This is a clot core, the whole, the material comes out like a thick clot. This can be directly put into formalin, and this can undergo histopathological processing. And one more method is, if you see on the left side, is a needle capillary suction method. This means that while you are agitating the needle, you are gently taking the stellate out rather than taking it out beforehand. So, this capillary suction method has also been shown, that it can use improve the yield of sampling. Regarding suction or no suction, there's no conclusive data, but this was one study which was done from our center, and we did find signal that no suction fared better than 20 ml suction. So I think the results were a little in a way it didn't come significant, but I got the feeling that no suction was a little better in terms of yield. The other thing is, if you've got a pathologist on site, they can help you in sample assessment. The pathologist can quickly see the samples and can give you a feedback on that idea. And the image on the right, you see, you can quickly, do the staining, and you can get an idea of a material. This actually photo has been taken by a smartphone camera. So you can use your camera to connect the photo from the microscope also, and you can, share with your pathology colleagues on WhatsApp, and, they can also give you good feedback. Regarding very important aspect, whether you do your procedure under sedation or you do it under general anesthesia. So I think this depends, on the setting also. Ours is a high volume center, and many of our patients also prefer sedation, and we, of the volumes, we, cannot, manage giving general anesthesia to all the patients also. And we feel it works quite well to do most of our procedures under moderate sedation. So if your patient is particularly willing that they want GA, or you yourself are more comfortable doing general anesthesia, you can have that discussion with the patients and do that, and that's perfectly fine. But always remember that topical anesthesia is cardinal. If you do deep sedation or general anesthesia, obviously the patient's ventilatory effort will go away. So you would have to need to put a airway conduit. So the airway conduits for GA are usually three. The most frequently used is a laryngeal mask airway, or most frequently an igel. You can also use a large bore ET tube, and rarely you can use a rigid bronchoscope. There are certain centers which use rigid bronchoscope quite a lot, but I don't think it's required too much. We've had to use rigid bronchoscope in one or two patients in which there was airway obstruction, and we want to gain access to the distal airway to open up the airway. So therein we used, this. So this is how it would look under general anesthesia. The anesthesiologist would have induced the patient, put a laryngeal mask airway, secure the laryngeal mask airway in place, and then they ensure their ventilation, which is going on by the bag. And once the igel has been securely, got it into place, then you are ready with your scope. And then, this is the swivel adapter. This is the adapter for a, entry of the bronchoscope. And you can, then introduce a bronchoscope through this. Patient is still, patient is not coughing, patient is not aware. And I think this does, makes the procedure definitely easy. But I think many patients do excellently well under moderate sedation also. So I think one has to take that call whether you want to do it under, that only. So concluding 3, 4 slides. So I was, happily to be a part of, this statement, which was quite interesting. This was a WABEP, position paper on quality indicators and reporting items in EBUS bronchoscopy. So essentially, what this paper was, focused at, that we all do EBUS TBNA, but do we report EBUS TBNA well? Do we know we are doing EBUS TBNA properly? So this is a kind of a self-audit kind of, guidance, that how you take with it. So, this has these, points which we addressed, that you always note the indication, why you did EBUS. You note that whether you are taking consent regularly, you are discussing with your patient regarding sedation aspects, how frequently your examinations are being performed by trained operators, because many of the centers, trainees are performing. So you have to take care that when a trainee is performing, it does not lead to a subtherapeutic procedure. So if you feel you are experienced and you are training, but you feel the sample is not coming well, you should know when you should take over and get that thing in through. Talk regarding sedation plan, anesthesia risks, and also, how do you record your EBUS reports? Did you note the relevant structures? Did you note the lymph nodes? How did you do systematic staging? You noticed complications, adverse events, and very importantly, if you notice the point 10, 11, that how do you audit yourself? How many inadequate samples did you get? What is your diagnostic yield? So I think these are the important things that all EBUS bronchoscopists should keep in mind. They should do a self-audit, and this would lead to improvement in their own, technique, and also of their center, and also of their trainees. So that's about all I would summarize by these few points. So patient preparation, a review of radiology, and discussion regarding sedation or anesthesia plan is crucial. You do that before you date the procedure, and do it again on the morning of the procedure or whenever you do the procedure. Cricothyroid lignocaine injection enables a more comfortable procedure if you are doing it under moderate sedation. If you are doing general anesthesia, this is probably not required. Oral and nasal bronchoscope introduction are both feasible, but if you have any issue with nasal, don't force the scope and quickly change to oral route. The sonographic lymph node characteristics and elastography are useful, but they do not, obviate the requirement for lymph node sampling. For lung cancer staging, very importantly, take a systematic approach. Say if you have a tumor on the right side, you start from the contralateral side, that's the left side, and start from the highest station. So you start from the N3 node, then come to mediastinal N2 node, and then come to the hilar N1 nodes. This is how you do it. Also, get sufficient material for pathology, microbiology, and also for molecular testing. Scope damage is one of the commonest and a pretty heavily expensive, complication. So always take care that your needle is locked before the needle goes into the scope. This one, thing, if you start doing routinely, is going to prevent your scope damage. Train your staff well. Rapid on-site evaluation by a pathologist, or yourself seeing your samples, or one of the members of your team seeing your samples, can be very useful. And as I talked about the last slide, you should follow up your yield, your sampling adequacy, do a self audit, and this will lead to continued improvement. Thank you.
So great, Karan. That was a fantastic talk by Karan, and it clearly, you get a message about both experiences from Karan. One is that he has a clinical experience. There's no doubt about it for more than a decade. And the second thing is the publication. So he's done a lot of, I mean, the people who do a lot of introspection and have a chance, they are able to publish and answer some questions. So the questions related to the technology and from a clinical perspective. So now I think it was a fantastic lecture where he from the preparation to the anesthesia to the procedure to the complications, all these aspects were very well discussed. So now I think we are going to go further, have a discussion with our experts from all across the country, and we will discuss maybe the similar things, the practical aspects, but a little bit more in details and taking the feedback of the other experts. So for this panel discussion, would like to now invite our dear friend, Dr. Avdesh Bansal. Can we put up the slide, please?
Is sir visible? Slides.
Yes. There you go. Yeah. The smart Dr. Avdesh Bansal, my dear friend, who's a senior consultant in the Department of Respiratory, Critical Care and Sleep Medicine at the Apollo Hospitals in New Delhi. And he's got all the qualification of Specialist Board of Respiratory Medicine from the DNB board. He's a specialist from the Board of Sleep Medicine, the National Board of Examination in Medical Sciences. He's a member of several the colleges. He's got the FRCP from Glasgow. He's got the fellowship of the Indian College of Critical Care Medicine from India. He's got the FRCP London, and he's also a fellow of the American College of Chest Physicians with the FCCP. And importantly, he's got more than 90 presentations, scientific presentations, and more than 35 publications to his credit. And I want to highlight one more important thing about Avdesh. Avdesh is not now you see the younger generation, often people will just start doing do EBUS TBNA. So Avdesh has a huge experience even as far as conventional TBNA is concerned. So an individual who's seen all all facets of diagnostic bronchoscopy and the evolution from conventional TBNA to EBUS TBNA. So Avdesh, great to see you. Thanks for joining in.
Thank you, Prashant.
Yes. Now, next slide, please. Next, we've got my dear friend, Dr. Vishwanath Bella, who has done his DM Pulmonary Medicine from PGI Chandigarh. He's the director and senior consultant at the Department of Pulmonary Medicine and Sleep Medicine, AIG Hospitals, Hyderabad. He's got 16 publications to his credit. And Vishwanath is also a is a fantastic clinician. He's an interventional pulmonologist doing several interventional procedures and is very, very actively involved as far as academia and teaching is concerned. So thanks, Vishwanath, for joining in. Yeah, we all look forward to your experience as well. Next slide. And here we've got, we've got Dr. Kranti Garg, who's an associate professor, Department of Pulmonary Medicine at the Government Medical College at Patiala in Punjab. She's member of various organizations from the IIB, ICS, NCCP, API, NAMS. She's got several awards to her credit, which includes the UAPM Fellowship in 2024, the NCCP Fellowship in 2022. She's got the Gurukul Citation Award on International Women's Day in the year 2013 for the contribution to the field of pulmonology. And she's got several publications and book chapters to her credit. Thank you, Dr. Kranti, for joining in and contributing to this panel discussion on EBUS TBNA. And lastly, I would also like to invite Dr. Rohan Aurangabadwala, who's a senior consultant at Apollo Hospitals. He's a colleague and a dear friend, and he's a fantastic pulmonologist and also an interventional pulmonologist doing interventional procedures at Apollo Hospital, Navi Mumbai. And Rohan has also spent a lot of time with our dear friend Ravi Mehta in Bangalore. So welcome, Rohan.
Thank you. Thank you.
Right, right. So now we move on to the panel discussion, and I think we are going to cover the same point. Whatever talk which we are going to go in more details. So let's start with Avdesh. Avdesh, can you please now he spoke on convex probe EBUS, but there might be some some individuals, as I said, who are not exposed to conventional TBNA. Some people are not exposed to the history of endobronchial ultrasound, and the history of endobronchial ultrasound began actually with the radial probe EBUS. So if you can just highlight the difference between the linear EBUS and the convex EBUS. The linear and the radial probe EBUS, please.
Thanks, Prashant. You're very right that it was in 2002 that the first radial probe actually came about, and the linear probe came much later after the gastric endoscopes started having the EUS basically. Then only this thing came about. So the basic difference is the transducer itself. In the radial probe, you have a 360-degree rotating transducer, okay, which creates an image which is 360 degrees parallel to the long axis of the bronchoscope. Whereas in the linear probe reverse, you have a fixed array of electric transducers which is aligned in a curvilinear manner. So it gives an image which is 60-degree parallel to the long axis of the scope. So you have a sector view, okay, whereas in the radial probe you have a circular view around the probe actually, okay. And the two most important difference between the two are that one is that you can do a real-time biopsy in the linear probe EBUS, which is not possible with the radial probe. Radial probe is used mainly to locate, identify the lesion, and then you have to take it out and put other biopsy forceps or brushes to do the sampling. Whereas the linear probe you can do the Doppler, and this is actually used frequently to locate the location of the various stations actually in relation to, let's say, either brachiocephalic vein at the top, trying to locate the 2R and 2L nodes, or the azygos and the SVC basically to identify whether the node is 4R or 10R basically, okay. So Doppler is very, very important, which is not possible in the case of radial probe EBUS. The other things like the frequency of the probe is almost 20 megahertz in radial probe, which is it is 5 to 12 megahertz in the linear probe, and the image quality is equally good in both. But the airway walls can be seen by the radial probe, which cannot be seen as nicely by the linear probe. So that's the basic difference, basically.
Great, great. Thanks a lot, Avdesh. So Avdesh has, very well highlighted the difference between the radial probe and the convex probe. And I think this gives you, the idea of this panel discussion for those who are new to EBUS or have started EBUS early is to just give you an idea about the important points. And I think that this becomes a platform for you to take your education further. So moving further, Karan showed you two different types of scopes. He showed you the Fuji scope. He showed you the Olympus scope. So I'd like to ask Vishwanath, can you very briefly tell the different convex probe EBUS scopes and highlight the important advantages and disadvantages of both?
Thank you, sir.
Or rather, all whatever which are available. Yeah, thanks.
Yeah. So I'll briefly touch upon different advantages and disadvantages of the different scopes actually. So the commonly used scopes are the Olympus scope, Fuji scopes, and the Pentax scopes, at least in the country. There is Hitachi also, but I think have not seen anyone using this Hitachi scope. So I'll take one point at a time. So in the Olympus scopes, the mode of transmission is through fiber optic transmission actually. Whereas in Fuji and Pentax, actually, the mode of transmission is through a charge coupled device actually. So just like our video bronchoscopes. So the endoscopic image is better in Fuji and Pentax scopes compared to the Olympus scopes. And if you come to the size of the scope actually, the smallest scope now which is available is the recent version of Olympus scope, which is the 190 series of Olympus scopes, and it is around 6.6 mm in diameter and has got a better flexibility than any other scopes actually. It's almost like a forward like 190 degrees bending is there, forward bending. As a result, you will be able to access the lesions which are there in the both the right upper lobe as well as the left upper lobe actually. This was not possible with the earlier scopes actually, and it is also not possible with the other scopes like Fuji or Pentax. This is an important advantage which I feel when you're using an Olympus 190 scope actually. So, and the other thing Karan touched upon is about the forward viewing actually. So if you look at the different endoscopic visions actually, the Fuji has got around 10 degrees forward viewing, and then the Olympus scope has got around 20 degrees forward viewing, and the Pentax has got around 45 degrees forward viewing vision actually. As a result, people who are generally habituated to doing a normal regular bronchoscopy, they might feel comfortable initially using either Fuji scope or the Olympus scope because the forward viewing angle is almost like 10 degrees or 20 degrees. But if someone is using a Pentax scope, sometimes it may take some time for them to get adjusted to the vision, because when they have this 45 degrees vision actually, when they're right on the vocal cords, what they'll be able to see is only the front portion of the vocal cords. So this might take some time to get adjusted actually. These are some of the three important differences. There is also small difference in the channel diameter, but the channel diameter like 2 and 2.2 in most of the scopes does not make a major difference in the yield or the technical success or difficulties actually.
Thanks a lot, Vishwanath, for highlighting the differences. So, for the audience, there are three common types of convex probe EBUS systems available. Essentially, all perform the same task of taking the samples. There are some minor differences in each of them, which have been highlighted. So, again, that's a platform.
Can I just add one point?
Yes.
The Olympus system obviously has the integrated image and the ultrasound, whereas the Pentax system has the ultrasound which is separate.
Yes, exactly.
And that becomes an issue with the licensing, where it is more difficult to take a license for this because it involves the detection of the male and female thing basically. And it's just a technical thing.
Yeah, perfect. Yeah, so I think and I think the factors that have been discussed are also responsible to a certain extent to the choice which a particular individual may do. So now moving on, I think we've discussed about the convex, radial, the different CP EBUS scopes. Now I'd like to come to Dr. Kranti. Can you just briefly tell us the indications and the contraindications for the convex probe EBUS, please?
Yes.
Yeah, very briefly. Thank you.
Thank you, sir. So when we talk about the indications and contraindications, first of all, talking about the indications. So we have diagnostic as well as therapeutic indications. Right now, we are using majorly our scopes for diagnostic indications. So the most common etiology, the suspicion where we are using our EBUS for the mediastinal lymph node sampling, that is for granulomatous pathologies like tuberculosis and sarcoidosis. Then we have lymphomas, and another important thing is lung cancers. So what advantage here I like to focus here is with mediastinoscopy. So in certain setups, mediastinoscopy is preferred over EBUS. But EBUS has an advantage that in cases of mediastinal lymph nodes, in cases of lung cancers, we can do the restaging. So lung cancer, it is used for diagnosis, it is used for staging, and for restaging, EBUS has an edge over mediastinoscopy because mediastinoscopy basically distorts the architecture. So restaging is not possible. Then other indications include the lymphomas, and we commonly have patients with extrathoracic malignancies. So what happens is the patient with a diagnosed extrathoracic malignancy coming to us, referred to us for mediastinal lymph nodes, and we have to sample the nodes to see whether it is a primary or it is some infection or something else. When we talk about, then we have various other indications. I have focused the main indications, others like thymomas. And then we come to the therapeutic indications. So in therapeutic indications, we have the aspirations of the mediastinal cysts, though we are not doing it much because as per the latest guidelines, it is associated with a very high complication rate. Then we have the bronchial injections, that is the chemotherapeutic injections. They are injected into the nodes itself. And here the EBUS finds a therapeutic indication, another therapeutic indication. Now coming to the various contraindications of EBUS. So we have some absolute contraindications where we should not go for an EBUS sampling, and we have relative contraindications. So in absolute contraindications, as we all know, for any procedure, an informed consent is the must. So first is, if we don't have the informed consent, then we have a recent MI, that is within last 4 weeks, if the patient has a recent MI or there is an ongoing unstable angina. Then another absolute contraindication which comes is that the patient is having an uncontrolled bleeding diathesis, or there is a benign or malignant stenosis of the upper airway, that is the supraglottic or the glottic airway. Then various other contraindications include the poorly controlled heart failures. The patient is having a significant hemodynamic instability. The patient is in an exacerbation of bronchial asthma or COPD. There is a life-threatening cardiac dysrhythmia. So now coming to the relative contraindications. So if the patient is in hypoxemia, that is the patient is not even able to maintain a saturation of 90%, even with 6 liters of oxygen. And we have a PO2 of less than 60. So in these patients, we can prefer a EUS FNA. And then we have a severe uncontrolled hypertension with systolic more than 180 and diastolic more than 110 millimeters of mercury. And then when the airway is narrow, that is, we have subglottic stenosis. Another one is a child less than 5 years of age, and we can be having some central airway obstruction. So these are few of the relative contraindications which I have narrated. So
So
EUS is one of the alternatives in few of the patients like
I think we will
narrow.
discuss EUS later, ma'am. Dr.
Yes.
Kant will discuss EUS later. I think there's just a point. I think, a large number, I think it has been dealt in details about indications and contraindications. Just a point is, as far as the mediastinoscopy is concerned, I think mediastinoscopy, I mean, I have a slightly different view on this. Is I think we don't discuss mediastinoscopy almost at all as far as lung cancer staging is concerned. And we've got a lot of randomized trials which also show that it's non-inferior to mediastinoscopy. Of course, there may be the occasional thing where you've got a negative test, you're still suspecting, you may want to do a mediastinoscopy, but the number of mediastinoscopy has certainly gone down. And of course, one of the reasons why mediastinal staging of lung cancer was not so common or popular in India was the inability to get a mediastinoscopy done. So I think EBUS TBNA has done a huge favor as far as the staging of lung cancer is concerned, and also in the restaging. So I think, now taking this forward, I want to move now to Dr. Rohan. Rohan, if you can just briefly, I think Karan did touch upon the routes of entry, that is nasal, oral, etc. But can you just, give a brief answer? My humble request to, we've got a lot of points that we need to discuss, and we are going to have a paucity of time. So, request to keep your answers very brief, please. Thank you.
So as Karan already said, it can be either the oral route or the nasal route. Most people across the country prefer the oral route as compared to the nasal route. Reasons: one, the scope size is larger as compared to the diagnostic or the therapeutic bronchoscope that we use. Also, there's a greater chance of bleeding through the nasal cavity if there is any obstruction or the passage is narrower, which is not an issue when you're using the oral route. So it's the ease of use, the comfort of use, the operator comfort and the ease comes in way. Either of the routes is fine as long as you're able to do the procedure comfortably and the patient is comfortable as well.
Perfect. So I think that's been very well, explained. One more point, Dr. Kranti, you mentioned about, aspiration of bronchogenic cyst. I think there are some case reports on that. People have done it, but I think if somebody is venturing into that, one must have a very good reason why other options were not chosen. So I think want to give a very clear message, and I would like to, other panelists to, if somebody differs on this, I think the aspiration of bronchogenic cyst should not be done as a first step. It should not be done as a routine. One has to be very careful, and we should have good reason. Karan, yes?
Yeah, I think cystic lesions of the mediastinum or cystic lesions per se carry a risk of infection, and the endoscopy guidelines recommend a lot of antibiotic prophylaxis whenever they, do a GI aspiration of a cystic lesion. So I think one thing is an infection risk, and second thing is, risk of mediastinitis complications are also there. So I think in case you feel that it's needs to be out, I think preferable would be to, take a surgical call. But I think on a case by case cases, it has been done It has been shown to be, working. So I think take a call, your comfort level, your expertise level, your thoracic surgery backup level, and the patient's willingness level. I think everything has to be taken into account.
Perfect, perfect. I think Dr. Kranti has given such an elaborate, indications, contraindications. We just thought a couple of points where we can get some comments. And one more point, about injections for chemotherapy. You've got a lot of Turkish data on that. Some of the Turkish people like to inject chemo in the lymph nodes. I've reviewed some of those papers as well. But I think we fail to have a randomized trial unless I've missed something on that. So for those who are venturing into EBUS TBNA, I think that's not the thing that you should consider is possible as far as the case reports are concerned. But I think I would strongly recommend that a very good multidisciplinary discussion be done before we venture onto that. Right? So any comments, Karan? You agree? Abdesh, you agree on this point? Yeah.
Yeah.
Perfect. So let's move on. Yeah. Yes. Vishwanath. Yes.
No, just wanted to make a point regarding the nasal versus oral route, especially when you're doing an EBUS under moderate sedation. Using EBUS scope through the nose actually will prevent biting of the EBUS scope by the patient actually, especially in settings where you're not able to give a deep anesthesia. That is one thing. But again, it depends upon the operator and their comfort level.
Absolutely. Yeah. So now moving on, Karan, you mentioned the different needles. Can you just give again? I would like request a brief answer. What are the different types of needles, and the advantages and important disadvantages from a clinical perspective, and which one is your choice?
Very practical question. You have a 21 gauge needle, you've got a 22 gauge needle, you've got a 19 gauge needle, and you've got a 25 gauge needle. So practically, these are the needle gauge which are available to you. Regarding the needle tip design, you have something called as a Procore needle, which comes by Cook. And there is a Francine needle called the Acquire needle, which comes by, the Boston. I think if you see comparative data have failed to demonstrate the superiority of one needle over the other conclusively. So I think, in individual cohort studies, there comes data that we got 90% yield, we got 100% yield, we got this. But I think till today, no needle has been shown to be conclusively superior to the other. Regarding our choice of needle, our go-to needle is either 21 gauge or 22 gauge needle. Our preference is for 21 gauge. In the EBUS survey from the country, the choice was also more for a 21 gauge needle by the operators. And we recently have, completed a randomized controlled trial comparing the new, the acquired Francine needle with the traditional 22 gauge needle. And we failed to demonstrate a yield difference between the two needles. It's going to be out soon. So I think I would say there is nothing much to choose as far as needle goes. You use needles yourself, and you get to a comfort zone which needle works for you best. I think cost also comes as a dynamic because many of the new needles are nearly twice or three times the cost of the standard needles also.
So I think Karan has, explained it very well. One point I really want to highlight for, if you've got residents, young doctors who are listening to this panel discussion, what Karan has done is if you see all the randomized trials, you pick up, a question which comes to you in your mind, which you want to ask experts, what is better? And when there is no data, that's the right thing to do a study about and a randomized trial about. And I think that's what you will see in a lot of the trials that are coming from Karan or from PGI, etc., and of course from other centers as well. Yes, Avdesh.
So the only thing I'd like to add is that the size 19 needle is being used now to create a puncture, whereby to take a intranodal biopsy, which is the latest use of 19 size needle because it is thicker in size. And also there are some papers which says that you get a better coarse sample from the 19 gauge needle to give a sample for the immunological markers actually.
Yeah, there are these case series which have shown that yes, it's possible to get a good core sample, but the randomized trial, the comparative trials have failed to show any advantage. Because what happens is that, if you use a 21 gauge needle, which happens to be my favorite also, and just flush everything into the cell block, I think you get a very good
sample
of immunohistochemistry, as well as you can do the gene panel as well. So, and again, as Karan highlighted, desirable to have a 19 gauge, you get a bloody sample. So your pathology should be able to handle the bloody sample also, because it's more blood with a large gauge needle and it's more expensive. So that's it. Yeah. Any other comment before we move forward? Yeah. So, if no further comments, again, I come to you, Avdesh. Again, you were referring to needles, so I want to take this forward here. I mean, are there any different type? No, we don't have a slide here, but if you can just explain the different parts of the needle which are important. People who are listening to this panel discussion should focus upon.
Yeah, I'm hoping that thanks, Prashant. I'm hoping that most of the people have seen the needle actually. So needle has the proximal portion, which is quite big in size, and I'll explain it in a second. And of course, it has the distal end, which is a sheath through which the needle actually comes out. Okay. So the proximal end has the bronchoscopic adapter. That's the first portion. That is the most distal portion of the thing which goes onto the bronchoscope, followed by the sheath adjuster, and then followed by what is known as the needle adjuster, through which you can decide as to how much you're going to go in, how much needle should come out. And of course, there is a stopper which makes sure that the needle does not go beyond that point. And then, of course, you have the actual needle slider, whereby you hold it and you go, you jab it, you go up and down. And then, of course, the knob in which there is a stylet. When you put the needle in, you must make sure that the stylet is always pulled out slightly so that the needle goes out smoothly. And then, of course, you use the stylet to push the material out, if there is any material which is going while you're putting the needle.
So perfect. I think what Avdesh has done is explain exactly, if the audience has paid attention to the videos that were shown by Karan, which was a very good practical depiction, demonstration of how the EBUS procedure is performed. I think you can relate to, and you can relate to what Avdesh said, and Avdesh has really highlighted the important aspects. Now, one important point I'd like Vishwanath, if you can highlight, is there any instrument preparation that is required before you do the procedure?
Yeah, ideally, we need to have a clean and sterilized scope before doing the procedure. Actually, make sure that it is sterilized from the previous procedure, and then check the scope for any external damages which are there, and just see whether your anti-flexion of the scope and retroflexion of the scope is working well or not. Attach the scope to the EBUS processor and see whether you're getting a good endoscopic vision and the ultrasound vision or not. Sometimes it might happen that you start the procedure and then you realize that your processor is not working well. So check all these well before the procedure itself. And then, as has been highlighted, make your whatever needle you are comfortable, make it ready, and also prime the needle with saline and keep it ready. And also the balloon should be worn on the tip of the EBUS scope before the procedure is done. And Karan has shown beautiful videos about how it's being filled and done everything. So I think this is the basic preparation regarding the scope.
Yeah, so as I said at the beginning of this panel discussion, it's just an expansion of current stock. So I think that's brilliant. Now, I'd like to come to Dr. Kranti. Dr. Kranti, we see the ultrasound keyboard, for example. The keyboard which is there, and it can be quite intimidating. There are so many functions on that. A pulmonologist is actually not used to seeing so many functions. So would like to request you to, if you can just highlight the few important functions which one should know from the keyboard or from the ultrasound, which are required for the EBUS.
Thank you, sir. So first of all, Dr. Karan has beautifully shown that node and the various characteristics which we need to see through the ultrasound. So the most important thing is that we should be able to measure the size of the node by using that ultrasound ball. So we should have the short axis and the long axis, because the characteristics of the node, that is whether the node is round or it is oval, as well as the short axis length, that is if the node is more than 1 centimeter or less than 1 centimeter. So there are various studies which help us tell that the node, these characteristics go towards a benign etiology, and these are the characteristics which go towards a malignant etiology. Though it does not stop us from sampling the node, obviously, because we finally get the diagnosis only once the sampling is done. Then we have to see the margins of the node, whether they are the distinct or the indistinct margins, whether the coagulation necrosis is there or not. We should be knowing the blood flow. That is how to use the Doppler from the keyboard, how we can shift between the ultrasound image and the bronchoscopic image. And then another important thing which Karan sir has already highlighted is the elastography feature of the ultrasound, which the latest machines help us. So it is said that the malignant nodes are a little more stiffer than the benign nodes. So if there is all blue, which Karan sir has shown beautifully with one of the pictures, so if it is all blue or it is predominantly blue, it goes towards malignant. And then we have the blood flow feature. So if there is higher vascularity, again, it goes a little more towards malignant. But the take home message is that the sampling is most important. We cannot rely on these various scoring systems. For example, we have the Canadian score. We see the central necrosis and the central hilar structures. They again help us differentiate. They are all ultrasonic features. Then we have the strain ratio, the strain patterns, the blue proportion patterns, which all are there on the keyboard. But yes, they cannot differentiate between benign and malignant. They can just support us in reaching to a conclusion.
Great. So I think many important points have been highlighted here. And now I think let's shift gears a little bit towards, again, towards the technique. And Rohan, Karan mentioned about doing a procedure under moderate sedation, under general anesthesia. And if you can just highlight, what airway conduits do you use and what's the rationale for it? Briefly, please.
We use the eye gel when we're using the GA. That gives us better access to all the lymph node stations. The other thing which can be used is an endotracheal tube. Only disadvantage with the endotracheal tube is one, you need a larger size tube. You need 8 or 8.5 size tube, which may not be possible to use in case of females or also the higher paratracheal lymph nodes cannot be sampled with the help of endotracheal tube because the 2R and 2L is so high, the endotracheal tube will not be an ideal conduit for them. So the eye gel, anything which stays above the glottis would be an ideal thing so as to sample all the lymph nodes. Again, rigid bronchoscope, as he mentioned, there are only a few centers which are using it. Most of the times you don't need a rigid bronchoscope. So these are the three conduits which are available. Eye gel is the most preferred in case you're using GA.
Perfect. Very well explained, Rohan. Thanks a lot. Now, again, we saw, we go back to the procedure that Karan demonstrated, and then he showed the suction being applied. So, and the sample being taken. Karan, could you please just expand upon the amount of suction that can be used and how many passes that should be done, taking into account that you might not have rows, which is not there in many of the institutions?
So regarding suction, I think mentioned there are a couple of studies which have tried to see whether suction or no suction works well. And ours was a pretty large study in which we had a signal that on eyeballing the yield was maximum in the no suction group. So there was a 0 ml suction, there was 10 ml, there 20 ml, and the difference between no suction and 20 ml suction was quite visible. That there was apparently better yield in no suction versus suction. The thing is, so what we do is that initially we try to do a procedure without suction. If you get a good enough material which is coming without suction, then there was no need to essentially apply suction. So we continue without suction, keep on taking the material. If we are not getting material, we are getting a dry aspirate, or you are getting a very scant material, then we would go ahead and apply a suction. So I think our way of doing it now is to try without suction, then go it with suction, and at the end of the procedure, when we are about to take a microbiological sample, when the pathological part is over, then we would apply suction. I mean, so you at the end apply suction that whatever is coming, it's a more material which you get, and then you do that. So that was about the suction. Your second question was
Number of passes.
Number of passes. So I think that is also, I mean, there's some data which says that if you get a visible core, you can reduce your per nodal pass from 3 to 2 maybe. That if you have gotten a good core which has come in your tissue. But I think as a rule of thumb is that 3 passes is, I think, what you should obtain per site which you have decided to sample. So I think that should be the minimum which you should do. I think this is a question which I'm not sure I have a clear answer based on evidence what we have for this. But I think if you have rapid on-site evaluation, you've made assessment that you've got adequate sample. I think then you can cut down. But if you don't have pathologists, if you yourself are not also seeing samples, I think a minimal of 3 aspirates you should obtain per station, and also try to obtain some core tissue.
Absolutely, and there's a paper from Taiwan which says that if you get 2 cores at a biopsy, then that could also give you the indication that you've got a likelihood of having an adequate sample. Coming to you, Avdesh, you explained the different parts of the needle. If you could just expand on one part, explain to the audience about the sheath. Why, how much sheath you keep outside, and why is it important to have the sheath outside and to be visualized?
So basically, once you adjust the sheath, you must make sure that the sheath is visible on the bronchoscopic image. The reason is that once the needle comes out, if the sheath is inside the channel, then it is going to puncture the channel itself, which means that the bronchoscope is going to leak. Also, if the sheath is inside, you're not sure whether it's going to puncture at the right place where you've decided to puncture actually. So it is important that sheaths should be clearly seen outside the bronchoscope, which means it is just seen, and current video very clearly showed that you see a crescent kind of a thing and you see the sheath is there. Sometimes we've seen the problem with the sheath is that the sheath tends to move inside or it moves outside, which means that before every pass, you have to make sure that your sheath is visible exactly as to how you want it, and maybe you need to adjust it. Also, sometimes you need to adjust the sheath when you are trying to put the needle in and there is a cartilaginous tissue which is coming in between. So you have a method known as it's like hub against the wall. So you forward the sheath to the extent that the tip actually touches the bronchial wall, and then you finally fix it, and then you push the needle out so that it becomes easier for you to pass through the cartilaginous space, basically. Okay. So the length of the needle is adjusted according to the size of the node, but most of the time it is 2 centimeter. But if you want node is bigger, if you have an area of hypoechoic area which is deeper, then you can obviously extend the size of the needle to be more. But you need to be very careful when you extend the size of the needle, because at times where there have been few cases where I've done the transvascular axis of the node. I have actually taken out the 4 centimeter size of the node. Okay, so that is a very, very rare thing. But otherwise, most of the time, standard is know the size of the node and then decide what is going to be your needle size, which is going to be out.
Perfect. So thanks a lot, Avdesh. That's a very good practical guidance that you've given all of us. Now, you've got the sheath out, you put the needle in, you've done the aspirate, you do suction, no suction. Move to you, Vishwanath. If you can also very briefly tell us how how the sample is removed and processed from the needle.
Once the needle is taken out of the target node, actually, the material which is coming out of the
Yeah, I think we seem to have lost Vishwanath's video. Yeah. I think we've lost Vishwanath's audio. Is that correct? Or others can hear it?
Yes, sir.
No.
Yes,
Okay.
sir.
Yeah. So I think let me take that. I think the sample needs to be removed with the help of a stellite. You put the stellate, you remove the whole needle out. You get the stellate, put the stellate in, and gradually see how the sample comes out. Again, as was shown on the video, you can either collect it on a slide, you can either collect it directly into the cell block solution, or you can take the sample flush directly with a normal saline into a sterile container. Now, moving forwards, Dr. Kranti, if you can just very briefly tell us, what all samples can be collected for various pathologies, please?
Yes, sir. So in cases of suspected tuberculosis, we will send the sample for gene expert liquid culture, and from that liquid culture, we can go for phenotypic DST as well. So when we are suspecting infections, obviously we'll be sending the samples for bacterial and fungal cultures. In cases of suspected malignancy, it is very important to have a cell block. So how the cell block will fare over slides is that basically we'll be having the sample for diagnosis, for subtyping, for molecular testing, as well as IHC. So cell block, it has been found that it has an edge when we are suspecting sarcoidosis as well. So cell block is one thing which we should definitely try to do. Then we can directly take the sample in an alcohol-based medium for liquid-based cytology. And then in lymphomas, we can go for flow cytometry. We can take the clots for that is the collection, the clots which comes in the needle. That can also be subjected to a histopathology.
Okay, I think that's great. If everybody can just mute, please. Those who are not, yeah, yeah. There seems to be some disturbance. Request everybody to mute. Thank you. There's some disturbance, so I request the web, the webinar organizer, if you can just mute everybody, please. Thank you. Now, we've spoken about the samples to be taken for various pathologies, including cancer and also for the benign things. What is really important now is, the scope was actually the first indication was staging of EBUS. Ron, I would like you to just highlight what are the important aspects that one should take into account or one should pay attention to once you're doing a staging EBUS. The important points, please.
Doing staging, basically you start from the highest contralateral node. So if it's on the right side, you will start from the left-sided hilar nodes, interlobar nodes, coming to the paratracheal nodes, then the subcarinal, and then the ipsilateral nodes. Uh, so that's how you would do a staging EBUS. Obviously, they will be while doing staging, that is why you're going from the highest contralateral to the ipsilateral. Also, sequencing of the nodes is very important while doing.
Vishwa, can I request you to mute, please? Vishwa, you can mute, please. Thank you. Yeah.
So the sequence of sampling of the nodes is extremely important as far as the staging is concerned.
Yes. So I think, like, simply what Rohan has highlighted, you start with the highest stage first, so that you are not, miss, otherwise there might be a risk in upstaging the patients. Yeah. So now, once we've discussed the sequence, Karan, if you're there, would like to again, if you can just re-highlight the role of the Doppler. You explained it during your procedure, during your talk, but if you can just highlight the practical aspect of Doppler. I mean, I hardly do a Doppler to look at the direction of blood flow. So the important points, please.
I think only to avoid vessels or vascular areas inside the lymph node. So you would have a situation, you see a node, you feel it's a node, but nothing inside, but you put a Doppler on and you can see, some wavy vessel-like structures inside the node or dots, which are, vascular. So it will avoid you to avoid an area, puncturing an area which you feel is, vascular. The other thing is sometimes if you're not comfortable in a view or your frequency is a little mismatched, a vessel may indeed appear like a node or a cyst-like structure, fluid-filled structure, may give kind of a atypical appearance. So I think, and we've seen this in clinical medicine also, on an ultrasound, which we thought was a pleural effusion, was a large dilated atrium. So I think, I think if you have that kind of a factor, it adds to your safety. And I think apart from that, it doesn't. From a research perspective, people have tried to see the utility of central intranodal vessel, CIV. But I think those are I think it's not a very
Yes.
practically,
So I just want to highlight a few experiences. Sometimes we've suspected pulmonary embolism, and we've done a CTPA after because you would see something within the blood vessel, and there are occasions when we could suspect a pulmonary embolism, which was subsequently confirmed. So secondly, we've also confirmed about tumor invasion within the blood vessels. So all those things can be seen. I mean, that's not something routine, but as Karan really highlighted, the most important point is to see to avoid inadvertent puncture of a blood vessel, and looking at the vascularity. You may be more strongly inclined, even if you're a suction first person, you may be strongly inclined to do a no suction method before you go ahead. We've I think the discussion is going great. Avdesh, if you can just highlight the role of the balloon. I mean, what's the role of the balloon? I mean, I know Karan mentioned it. If you can expand a very little bit on that.
So balloon application itself sometimes can be very difficult because people are not able to take out the air, and that is something which is very, very important.
It's a
But the
business.
most
It's
important,
expensive business.
yeah, exactly. But the most important use of balloon is in areas, especially in elderly patients, where there is a gap between the cartilage rings. And when you try to oppose the transducer, it's not able to oppose properly. So balloon will make sure that you're able to oppose and there is a continuous touch basically. So you have a better image. And also, you must remember that when you're doing evoscopy, frankly speaking, you don't see the transducer at all till the time you inflate the balloon. So you should be able to inflate the balloon only till the time you see a crescent. So you should not completely fill it. Just see a crescent, and that's probably more than sufficient. Another use of balloon is to do TBNA at difficult sites, especially 4L, and sometimes the higher nodes on both the sides to stabilize the. We found that if you have a balloon inflated, you find the scope to be more stable. It does not move so much with the movement. Okay, so balloon helps you to do that also. But the most important thing I always say is remember to deflate the balloon, because we've seen number of times that balloon remain inflated, and then the guy started to desaturate, and then it becomes a problem basically, especially when you're doing it in the trachea itself. The 4R nodes basically. So
Perfect.
it's important. Yeah.
So I think you've explained the role of the balloon. I know we don't have the screen share possibility now, but can you explain some of the important points, Vishwanath, about the balloon application? Some tips. It's expensive business. If if the balloon bursts and you have to put a new balloon, or the balloon tears, yeah. How do you prevent that? Yeah, unmute, please, Vishwanath. Vishwanath, unmute, please.
Yeah. So I missed the last part of the question, sir.
No, so what I'm saying is, Avdesh explained the importance of the balloon. If you can just highlight one or two important points as far as the balloon application is concerned and how the air has to be removed.
So one of the important things in the balloon application is taking out the air actually. So you first apply the balloon over the tip of the EBUS scope. Before, there is a small mechanism to lock the balloon over the EBUS probe actually, transducer actually. Before you lock the balloon over this transducer, you inflate the balloon, try to push some saline into the balloon and see whether there is any residual air bubbles there. Sometimes you find that there are no air bubbles at all, but sometimes when you find there are air bubbles, there are two things which we can do to take out the air bubbles, because air bubbles are the enemy for the ultrasound waves actually. So the first thing which we do is basically from where we inflate the ultrasound, the balloon actually, we apply, like we pull the plunger back to see if the air can be pulled out actually. So you can do it repeatedly. To suppose if you see an air bubble in the balloon actually, you apply the syringe, pull the plunger back, aspirate the air into the syringe, and then again you put back the syringe and then do it couple of times actually. Most of the times, in couple of times, 2 or 3 times, you'll be able to take out all the air bubbles which are there in the balloon actually. And the other technique which we do to take out the air bubbles from the balloon, or to before we lock the balloon or the EBUS tip actually, what we do is we put it erect actually. Take the help of the gravity. When you put the EBUS tip upwards actually, what it does is the air bubbles come up actually, and then you just use your finger to just take out the air bubbles out actually from the tip of the EBUS scope actually. Couple of times if you do that, that's more of a practical demonstration point actually, which we can show probably during an workshop.
Perfect. Yes, yes. I think you're right. That's actually the material for a workshop. But I think you've done a great job trying to simply explain, some important points, how one could, try to get the proper balloon application, and also how the air has to be removed. The important point is, let the air come up and then you can squeeze out the air. And most of the time it works. Really important not to burst the balloon. Now, coming to Dr. Kranti, I mean, complications of EBUS can be, a talk by itself. First, can you just highlight a few important complications which one should be aware of during the EBUS, please? The common ones?
EBUS is actually a very, very safe procedure, because what we are seeing, that is when we are puncturing, we are actually seeing that what we are entering. So we are able to see the vascularity. We are obviously very, very careful whether we are puncturing the vessel or not. However, despite being a very safe procedure, we can have some minor complications like transient hypoxemia could be there. There could be transient bleeding. So that bleeding usually is controlled with cold saline and adrenaline. Then we can have a laryngospasm or a bronchospasm. We can have fever. Uh, the major complications are very, very rare. So they have been reported to even the tune of less than 0.01%, and they include the pneumomediastinum, the pneumothorax. There could be a respiratory failure. There could be hypotension. And another important thing which I'll like to bring about the complications is the needle and the assembly and the scope. So we may be doing the procedure, but we may be injuring our scope. As sir has already told, the safety of the stillet and everything. So we have to be very careful while we are using the needle. There have been instances of needle breakage. There have been instances of stillet being stuck up while taking out the assembly. And yes, there have been instances of scope damage. So they are also the complications which will be complicating the further EBUS procedures, which we will be doing.
Perfect. So I think that's a big, in a nutshell, about the EBUS. Yes, Avdesh?
Can I just add that when you push the needle into the node, you should do it slowly. That's really, really important because we've seen a number of times that if you try to jab it, the needle can actually bend, and then it becomes difficult to get the needle back into the sheath.
Yes, sir.
Yeah, that's also a very important.
We
Yes.
should always check the assembly before we are puncturing it. After every pass, we should try to inspect the assembly physically before we take
Yeah.
the second pass.
Yes, Karan.
I think other thing is that avoid needle reuse. That's I would say.
Yeah.
A reuse a needle which gets bent at the tip, that is also more likely to get stuck. It is a risky issue, I think. And the other thing is sometimes if you are trying to puncture, also realize the limitations of science. There will be some patients in whom the nodes will be really fibrotic. It will be a hard node. It will be like a fibrosing mediastinitis situation. You are trying to put the needle, it's not going in. You will have this situation sometime. At that time, you have to, if you've done, say, a couple of procedures, ki it's not going. I mean, respect that sometimes, and you should know when to stop the procedure. Otherwise, if you are really aggressive with puncturing a very hard node, needle may enter and it may then, break.
It's
So I
stuck.
think we are fortunate not to have had this complication, but I think no one should land into that complication.
So I think Karan, that's really very well explained, and I think I must also say that Karan has been answering a lot of questions that have been coming online. Karan, there's one more, I think, question that has come about the cryo EBUS TBNA. Now that you mentioned hard lymph nodes, you mentioned fibrotic lymph nodes. Can you just very briefly tell us when you would do a cryo EBUS TBNA and where do you place it in your practice?
See, what has happened is there's reports coming on cryo EBUS TBNA. See, we've been doing EBUS TBNA and we've had reasonably good yield with that. Now, data on the cryo EBUS, we recently did a meta-analysis, pooled in all studies available which have done cryo, and see what is the incremental yield over EBUS. So the incremental yield of cryo EBUS versus EBUS was 9 to 10%. So there is an increment in yield, but does that justify subjecting, a kind of near routine use? I would say we don't have data to support that. So I think our approach would be to try it out in a non-diagnostic EBUS TBNA or in a situation in which we are doing the procedure, material is not coming, or we have got rows and we are finding that it's kind of a very minimal scanty aspirate, and this patient is likely going to get a non-diagnostic sample maybe on our experience. We would try to switch on to whatever. So there's a very nice paper by Dr. Nagarjuna from Hyderabad, where he has done a subset in which cryo-EBUS was done for rose negative subjects. And what was found was that there was a reasonable, increment in the yield if you do. So I think what should be done at the moment is use cryo-EBUS on a case-to-case basis. You are an experienced operator. You are getting your yield with EBUS. For a malignant node, data does not support that cryo yields to increase in yield. So all the studies, the malignancy subset, you don't have an incremental yield. So this means just to say that I will get more material for molecular diagnosis, I will get more diagnostic material in cancer. We don't have data. In fact, the data says it's nearly equal. The yield increased in the benign subset. So maybe I think it's a technology in evolution, but we would try to use it considering on a case-to-case basis in a non-diagnostic setting, rose negative setting, or in our setting in which we feel that there's a high possibility of non-diagnostic material.
Perfect. Thanks a lot. Thanks a lot, Karan. That has also taken. That's also given an opportunity to cover some of the questions that have come up in the chat box. Now, Dr. Kranti mentioned about complications of EBUS, and Now, one of the complications that can happen, and an expensive one, is damage to the scope. Rohan, can you just highlight some of the important practices that might help us to prevent damage to the scope?
Yeah, so most important thing, experienced operator, experienced technicians to make sure that the user of the scope is experienced because it's expensive scope. Second, when you're inserting the needle, all the steps of needle insertion have to be followed at each point of time. So you have to make sure that the needle is properly locked, the sheath is visualized before you puncture the node, because if you don't do that, you may inadvertently puncture the scope and cause a channel damage. Also, if you're using a conduit, you have to use lubricating jelly or xylocaine jelly at each insertion so as to reduce the wear and tear of the outer sheath. Otherwise, it can also get damaged. Avoid excessive flexion of the scope while you're inserting the needle because that itself can be causing a lot of wear and tear. These points have to be kept in mind at each puncture so that you do not inadvertently damage the scope. Also, if you're using it under moderate sedation, make sure that you have a bite block in place and the patient is not biting on the scope so as to prevent the damage.
So brilliant, brilliant. I think the important points as far as the practices that need to be adopted to reduce the scope damage have been very well explained by Rohan. I've got a I've got a question for Karan coming up. But before we go on to that question, I'm just going to the chat box, and it's amazing. We've got more than 2,000 doctor logins. That's really amazing. There are a lot of questions which are there on the chat box, which Karan as very efficiently as always has already tried to answer about them. That's about the needle size, about the cryo. This has been addressed. Also, again, Karan also discussed about the inadvertent needle breakage and how to prevent, particularly for the hard lymph node. That has been also taken into account. And again, also there were questions about about GA, about doing EBUS under GA before progressing to moderate sedation for people who are initiating EBUS is done. Again, it's typically a safe procedure. It's equally feasible, as Karan rightly points out, is you could start with either moderate sedation or even a more deeper or a general anesthesia. Now, it really depends on what your what your training has been, whom who's been your mentor. So typically people try to follow the steps of the mentor. You want to use the same, wherever you've trained, you want to replicate the same thing. So I think it's okay as far as both moderate sedation is concerned, or even general anesthesia is concerned. General anesthesia, as was mentioned earlier, many people are just comfortable using the eye gel mask. Now, there's a question about how the procedure should be performed with an endotracheal intubation. I think that question also has been taken by the panelist, and they said that yes, if you're doing it through the endotracheal intubation, you need to really withdraw the endotracheal tube as proximal as possible. And particularly, it should not be a problem to do right paratracheal, left paratracheal, or even the subcarinal lymph nodes. The issue can happen only if you got the higher paratracheal uh, stations to be sampled. So that also has been explained very well. Then I think, how does convex EBUS compare to other imaging modalities in lung condition? And I think, we also discussed, as Dr. Kranti had also mentioned, about the indications. Clearly, it stands if the randomized trial show it is non-inferior to mediastinoscopy. But yes, it is already very efficient to mediastinoscopy from many aspects. There have been also, again, Dr. Kranti there's a question about intranodal chemotherapy and other chemotherapeutic aspects. Dr. Kranti has explained that in her panel discussion as well. And as I also mentioned, as far as the intranodal chemotherapy is done, you need, I haven't performed it, and you need, if you are thinking about it, it has to be after a multidisciplinary discussion and should not be considered as a routine. There was also a question about performing the procedure in a tracheostomized patient. And now understand, as far as and also that has been answered very efficiently by our panelist, is that you can try to remove the tracheostomy and go to the stoma. The reason being, once after 2 or 3 days, the tracheostomy is mature. You can remove it. You can ventilate the patient as it is. You just need to make sure that you've blocked the tracheostoma so that ventilation is feasible. You can do the procedure, and if need be, the tracheostomy can be put back. And clearly, you need to do this along with the anesthetist. Yeah. Also, what are the add-ons in the convex probe EBUS? I think that have already been discussed as far as the entire panelists are concerned. I think the benefits of convex probe EBUS and also about the various ultrasound parameters which are available, which can be used to enhance the yield, has already been discussed. Now, again, a question about the needle gauge is concerned. There is the question is that the 22 gauge needle has disadvantage in sampling the 4L lymph node because of the stiffness. And I think our panelist has already answered that question. It may be actually a bit easier or almost with a 22 gauge needle or similar with a 21 gauge needle. And one point I like to add here is if you use a 19 gauge needle, it's more flexible. It has an 84-degree flexibility. So typically, if you've got a left paratracheal lymph node where you can't have an opposition, or you put in the needle and then you lose a position, you can't get a good vision, you may consider to use the 19 gauge needle. Is expensive, but then you get a very good flexion. Another option is just go to the EBUS BFNA, and you can get the left paratracheal through that approach. What are the technical differences between CP EBUS and radial EBUS? I think this has been very well described by Avdesh at the start. And again, there are questions about the needle size, the number of passes. Again, I must say that these questions have also been discussed by our panelists. There's another question about advantages and disadvantages of fixing the sheath. That has also been very well explained by Dr. Avdesh Bansal, and that question has also been taken. So I think what has happened is that a lot of these questions have come ahead of time before we could go ahead with the panel discussion. And it's interesting to see that our panelists have actually addressed a lot of the common questions. One question is, what is the role of CP EBUS in peripheral lung lesions? I think the CP doesn't have a role in peripheral lung lesions. It's a separate topic by itself. You can use a radial probe for peripheral lung lesions. Indications and contraindications has been asked by somebody, and would like to tell the doctor that that has also been covered again by Dr. Kranti very well. Then there is would positioning and preparation impact the quality of EBUS images obtained from convex probe? Yes. I think it is unlikely to affect the quality. Whether you do it in the complete supine, we typically do it in the supine position, but there are centers worldwide who would do it in a semi-reclined position and do it from the front. So again, it really depends on the institutional practice. So there's one institution where I worked for many years where I had to put the scope from the front. Well, that was they didn't have an OT table like I have. They had a chair, and you had to do it through the chair, and everything really worked very well. So another question is how to locate the perforation site in mucosal layer of trachea easily if multiple puncture is needed. I think that is also explained very well, that how you need to go pass the needle in. If you're having difficulties, you just need to move the needle, your probe a little bit, and try to get a good access. And the hub against the wall technique has also been described very well by Dr. Avdesh Bansal. The next question is, can cricothyroid lignocaine? I'm sorry, I'm not putting across these questions again to the panelists because all these questions have already been taken. Yeah. So in interest of time, I'm just summarizing what our panelists already said. Can cricothyroid lignocaine injection be attempted for anesthesia in diagnostic bronchoscopy? And Karan, who is doing has said yes, it can be done. But I mean, I must say that again, I think there are a lot of papers which are favoring precothyroid injection, but a lot of us are also are doing the procedures without precothyroid lignocaine injection. So I think it's about your choices and the comfort levels. Yeah, the data is there are also papers supporting either way. Now there are almost 51 questions. Yes, we've tried to take all these questions here. How does the diagnostic accuracy of EBUS compare with traditional imaging techniques like CT? You can't compare them. With EBUS, you are actually doing a pathological diagnosis. With the CT, you're doing a imaging diagnosis. One question, interesting. I think uh, somewhat was referred to. If somebody would like to take, what are the lymph node forceps biopsy efficacy and indications? Who would like to take that? Yes, Karan.
So I think lymph node forceps biopsy means through the puncture site, you put a small forceps or you create a separate opening to put a forceps, like using an electrocautery. I think in our experience, what we feel that even if you get a forceps inside with difficulty, the failure rate of getting a biopsy is quite high. So you go in,
Opening.
you try to bite, it doesn't open, biopsy doesn't come
Yeah.
out. So I think I think if we talk about cryobiopsy versus forceps, I think technically the cryobiopsy is more feasible as compared to forceps. But I think then the question comes again, which are the patients who should be subjected to a procedure beyond EBUS TBNA? So that you should think. And I think then you can take your call. With your experience, you may get a diagnosis forceps biopsy also. But I think you should see what is available to you and whether your patient needs it, I think.
Yes,
So
there's another. Yes.
one of the indication could be lymphoma, where you need definite tissue architecture, and this is where probably cryo biopsy of the node may help actually. Another question which somebody asked was, is there any role of CP EBUS in the peripheral nodule? The answer, frankly speaking, is in research. There are preclinical trials going on at a scope which is 5.9 millimeter in size. The Olympus is doing it actually. And this scope can actually go to the fourth generation of bronchi, which is 3.3 millimeter in size. So there are chances that in future you might be able to actually do live biopsy of the peripheral nodules. And of course, the third point is that the same CP bus can be used for the EUS also. So combining the two, conventional EBUS TBNA versus EUS TBNA can actually complement as a media cystoscopy in these patients. Okay, it rules out the use of, because you can then take station 8 and 9 as well, and other nodes also.
Perfect. So I think again we've got fantastic inputs as far as the questions are concerned. There's one question also that has come up that is I think it's a very practical question. How do we tackle the problem of image blurring during actual insertion of the EBUS FNA needle? Who would like to take that? Yeah, Vishwanath, you want to take that?
Image blurring during the insertion of the, so most often the reason for blurring is basically some secretions on the tip of the camera, sir, actually. Just like how we clear the bronchoscope and clear the vision, actually, that's how we do it also. We just go into the trachea, we antiflex the scope and just rub it against the anterior tracheal wall so that the secretions get dislodged. If it doesn't clear the vision, then we often use saline to push the secretions or whatever away from the lens so that your vision becomes clear, actually. And sometimes that also becomes difficult. And if the clot is actively stuck to the bronchoscope, then we take out the bronchoscope, we take out the clot which is adherent or secretions which are adherent to the scope and clear the scope.
Perfect. So
Actually,
I think that's a very good common issue that if you sort that out, you can get a good vision. There's one more thing, one more reason why that can happen is because the minute you push the needle assembly into the scope, it makes
Straightens.
it's some sort of straightens the scope, so the apposition to the airway wall can become less. And now if the apposition to the airway wall can become less, clearly you've got air coming between the transducer as well as the airway wall. And I think this is the time, I would strongly urge not to try to be very aggressive with the flexing of the scope. This is the time to actually adjust inflate the balloon, and
Balloon, yeah.
adjust it, and then with a gentle flexion, I think typically one should be able. Another thing what you can do is, as was Rohan pointing out, you can rotate the scope also a little bit, and then you can get a good visualization. Yeah. So I think this is the most of the practical questions have been covered. How might artificial intelligence help as far as EBUS diagnosis is concerned? I think we need to wait. I think we are at this there are many things which are in research, some of them which Avdesh also referred to. But I think that we can keep going and on. We've almost nearing 2 hours of the discussion. So now that we've covered most of the questions which are there on the chat box, I'd like to ask Karan, the speaker, the first question and the last question to you. How can one really train on the simulator, and can just training on the simulator prepare you for doing the EBUS procedure, or the EBUS stimulator is just something to make you more comfortable and make you less anxious as far as learning of the EBUS is concerned?
Yeah, so I think nowadays there is also focus on simulation. So I think if you have seen or experienced something, even say as a experience, the second time once you come forward for that circumstance, you feel more comfortable. So I think if you've had experience or practicing on a stimulator, you will feel more comfortable if you say approach a real life situation. But on the other hand, if you have been in clinical training with doing and seeing and learning EBUS on the go, I think you may be equally well, comfortable in actually, starting to do the procedure, because you will mostly be a bronchoscopist before you start learning EBUS TB. And I think that is also one message what needs to be passed, that you need to learn bronchoscopy before you learn EBUS TB. So I think
Yes.
this was something which was, I think Dr. Avdesh would second me, that if somebody can learn to do conventional TBNA,
Absolutely.
that is the person who can do bronchoscopy well. I mean, conventional TBNA is if you can do that, this means you can control the bronchoscope. And unfortunately, because conventional TBNA training has reduced so much, that EBUS TBNA has taken over, that the training of bronchoscopy has suffered. So I think whenever you get an opportunity, you see a large subcarinal, large paratracheal node, especially a malignant node, do consider cTBNA, and you would not be surprised at how often you can get an answer. So I think learn bronchoscopy first. Try, you can learn a bit of conventional TBNA also. It's difficult in training is to today's date, but still try. And then I think if you can get the opportunity to do a simulator, you got no practical EBUS experience, no mentor, no training, then it's fine. But if you are working at a center where EBUS is being performed, I think you can learn on the go, and then you can move on to EBUS also.
Yeah, so I think that's so very well put across. I'm going to take opinion of all the panelists on this particular point. But before that, there's another question that's come up in the chat box from more than one person. Maybe is about how does convex probe EBUS compare with the surgical staging in lung cancer? I think you know about 2 decades ago, mediastinoscopy was the standard of care. But as we discussed earlier, a lot of randomized trials have shown it is non-inferior. And there are some trials from Toronto which have actually gone ahead and said that is actually superior to as far as the surgical stage is concerned. So I think the message that comes across is it's just not out of bias because we do EBUS TBNA, but we've got a lot of literature to support that EBUS TBNA is actually superior to that. Yeah. So now again we come to the same point that was where Karan was discussing. Avdesh, any thoughts you would like to add to that, please?
I think I have worked on the simulator, and believe me, working on the simulator is much more difficult, I find, as compared to working on the actual patient. Okay, so that's my personal experience, and I found it difficult to learn on the simulator. So, like Karan said, if you work in a high volume center, it's actually on training on the go, and it's really important to start with the normal bronchoscopy. You should know how to handle the scope before you go on to the EBUS TBNA. We've seen our DNV students, they before learning the bronchoscopy, they actually want to do the TBNA, which is wrong.
Right. So now, that brings up a very important point. You said about I think we brought conventional bronchoscopy and EBUS. There are people, who've come to, I mean, with due respect to everybody, but we've come across some people who've come for an EBUS course, and we start by teaching them how to hold the bronchoscope. That's not fair, friends. That's not
That's
fair.
not
I
fair.
think
Yeah.
if somebody really wants to pursue, pulmonary endoscopy. I don't want to use the word conventional bronchoscopy, advanced bronchoscopy, interventional. I just say pulmonary endoscopy. Then one really needs to go step by step as far as the learning and the practical application is concerned. There's a question that has come up. Can we skip video bronchoscopy prior to linear EBUS? And, Rohan, you want to take that?
No, you should do a conventional. As in, you can use the endoscopic image of the EBUS itself, but it is always prudent to examine the airway before you venture in with doing your EBUS. If you get an endobronchial lesion, you might as well sample the
Yes.
endobronchial lesion prior to doing an EBUS. So it's always better to inspect the airway, make sure everything is fine. If at all there are any secretions or stuff, you can do a BAL, collect the secretions. So it is absolutely mandatory to check the airway before you do a puncture. I would do it in all my cases.
Absolutely. So I second that. I think a flexible bronchoscopy is really, I would say a white light bronchoscopy is required before performing an EBUS TBNA. You can often see lymph nodes eroding into the airway. You can find endobronchial lesions also, which you might not have suspected on the CT scan. So I think it is, I would say it is a standard of care. And if you use, I think there's whatever said and done, these scopes, which have an angle vision, may not be the best suited. They are large in diameter to look for endobronchial lesions. So you can't go really very distal with a 6.7 millimeter distal diameter or a 6.9 millimeter distal diameter scope. So although one can argue and say, yes, with a lesser angle, you can see the endobronchial tree, but there is a potential to miss if you're not able to go into the airway segments, you could potentially miss. So I think it's something very simple. Come on. I mean, if you're going to do an EBUS TBNA, it takes a few minutes to just pass the scope and have a look. So I think that question is well answered. Coming back to the question about the simulator and the training, Dr. Kranti, what are your thoughts?
I'll also agree with Karan sir. I think first the student should be very, very apt in doing a flexible bronchoscopy. I don't think then EBUS is just a game. Because what he'll be learning from that conventional TBNA and from the hand, how his or her hand is moving on that flexible bronchoscope, the whatever done through the flexible, that will be under direct vision when the person is doing an EBUS. So simulators, I have also been, I have done my training on simulators. And as Avdesh sir has said, it is really difficult because you simply don't know where are the nodes and you simply don't know where you are actually in that simulator. I think if you are good at flexible bronchoscopy, EBUS can be simply learned.
Yes, yes. So I think yes. I mean, there are pros and cons, and people who support, who do not support, as far as the simulators are concerned. It's also expensive business. To maintain
Yeah.
the simulators, you need to get grants. You need to get, I think we are already sweating out, trying to get an EBUS scope, and then to ask for a simulator. Yes, I think it's important that some of the major teaching institutions have it. So I think I personally feel that simulators should be are important, but I think they can be at very limited teaching institutions and don't need to be present at every. Yes, yes, Vishwanath, any comment?
So in this aspects, I just would like to add one more thing actually. Either in the porcine models or the breathing things, they have lymph nodes along the trachea actually. So before one ventures into the humans actually, before doing, if they want more confidence, if they have a simulator, they can use that, or else they can try on a porcine model actually, breathing pics or something like that during a workshops actually. We should give them more confidence.
So brilliant, So I think it's 10:30. We've done almost 2 hours of a teaching session. Really grateful to the organizers, that is the IAB, entire IIB team, which has organized this possibility of people to come online. More than 2,000 people online, still there, trying to learn from the panelist and from the speaker about EBUS TBNA. I think it's been a great learning. Even I've got to learn some important tips. It's a learning process. So really would like to thank all of you, the speaker as well as the panelist, for this excellent learning, and also for the audience for putting in important questions, and which have allowed us to make the discussion a little bit a wholesome discussion. There are certain points in the discussion about sedation and fellowship trainings, etc. But I think I think IIB is very active, and I think the IIB Secretariat can probably help you if you have any questions about the training. Any comments from anybody before we switch? Yes, we've got Mehul here. Mehul joined in. Mehul, you want to say some few words?
Sir, I'm just there to wind up once you guys are done, sir. So I think let's take the word from the panelists and the speaker, sir, first.
Yes. Any final words?
So Prashant, I would like to say thank you so much. You've done an excellent, you conducted it really, really well. Karan had given a very good lecture after a long time. I heard a succinct thing basically. So thank you so much.
So great. Yeah. So Mehul, over to you.
Yeah, so thank you to all the panelists. First of all, I'll thank Dr. Karan Madan for giving such a lucid lecture. All the videos were top notch. And I'd like to thank all my panelists, Dr. Avdesh Bansal, Dr. Vishwanath, Dr. Kranti, and Dr. Rohan, and the captain of the shift today, Dr. Prashant. What I would need to say is all the questions that have been asked in the chat box, everything will be discussed in detail in future webinars. So don't miss those. You have all the topics covered, the forceps biopsy, the difficult situations, the cryobiopsy, everything will be covered. We have all our lectures live on the YouTube channel and on the website. This also will go to the YouTube channel in a couple of days. And I would like to also thank our academic partners, Mankind and Olympus, for this opportunity. And to all the 2061 people still listening to us, I can see what is the level of interest EBUS generates. But we'll have lots of hands-on. All your small questions, small queries, you can write it down and come to the hands-on session when they are there, and probably you'll get your answers directly one-on-one from the experts. So I thank you all for staying back for so long, and good night to everyone.
Yeah.
Thank you.
Thank you.
Thank you.
Everyone. Thank you, sir.
Thanks a
Thank
lot.
you.
Thank you very
Thank you.
much. Great to see all of you.
Thank you, sir.
Thank you
Bye.
so